Welcome to Module 3, Clinical Transition Planning, planning safe and sustainable transitions from hospital to community. This is the third practice series of the educational series, Capacity Building in the DS Sector, enhancing support for people with dual diagnoses, alternative level of care that have transitioned into the community, presented by the Specialized Clinical DS Network. In this module, we're going to focus on what makes transitions successful, not just in theory, but in practice. My name is Cassandra Ferrugia, and I'll be guiding you through this module alongside Jenny. She joins us from a position of lived experience. Having transitioned from hospital to home herself, she understands firsthand what can support a successful transition, as well as some of the challenges that can arise along the way. Her perspective helps ground this module in real-world experiences behind the systems and practices that we'll be discussing. Before we begin, let's briefly situate where we are in your learning journey. In previous modules, you explored intellectual and developmental disabilities and dual diagnosis, as well as crisis prevention and de-escalation strategies. Those modules focused on understanding individuals and responding in the moment. This module shifts the focus to what happens next, specifically how we plan for safe and sustainable transitions out of the hospital and into the community. In each module, you will see some important symbols to direct your learning. The first symbol on the list is a prompt to make sure you have the module reflection handout in front of you. This will be a helpful tool for note-taking and completing activities throughout the module. The second symbol indicates a key definition. A list of all definitions can be found in the resources section for the series. Next, the worksheet image is a prompt to look at your reflection handout to complete the activity. And finally, the Learn More icon will highlight a relevant resource that may provide further information and learning. Many individuals remain in hospital not because they require acute care, but because the system is not yet ready to support them in the community. This is the core issue we're addressing in this module. Across Ontario, a significant proportion of hospital capacity is occupied by individuals that are designated as ALC patients. As mentioned in the previous learning module, Alternate Level of Care, ALC, is a designation for hospital patients who no longer require acute intensive care but remain in a hospital bed while waiting for a more appropriate setting, such as a supported living environment like group homes. It often signifies a delayed discharge, meaning they no longer require hospital-based services but cannot yet transition safely to the community. These delays are often not due to clinical instability, but due to gaps in planning, coordination, and system readiness. When transitions are not well supported, individuals are at an increased risk of readmission, often within the first 30 to 90 days. We also see transitions break down when expectations are unclear or when there is limited coordination between hospital and community teams. The impact is significant for individuals. This can mean loss of independence, reduced quality of life, and increased behavioral complexity. At a system level, it contributes to a hospital strain, delayed access to care, and increased overall costs. This is why structured, intentional transition planning is so critical. By the end of this module, you'll be able to identify key indicators of clinical and environmental readiness for transition, describe the roles and responsibilities of interdisciplinary partners, apply practical risk mitigation strategies, and identify best practices that support continuity of care following discharge. As we move through the module, we'll build these skills step by step. To make this content more practical, we'll be working through a case example that we'll revisit through the module. This case is designed to reflect common transition challenges you may encounter in practice. But before we introduce Michael, we'll pause here for a reflection from Jennifer. She was asked to reflect back to her admission and think about what she wanted her care team to know from the jump. Jennifer states, "My medical conditions are challenging, but it doesn't define me. I want staff to know that I have a lot of hobbies, friends, and strengths, and I want to be treated for who I am and not my disability." Meet Michael. He's a 32-year-old male with autism and an intellectual disability. Previously, he lived with his elderly parents and younger sister. He had access to direct support professionals twice a week for 3 hours. He would be supported with community outings and preferred activities. He was admitted to hospital following escalating aggressive behaviors that became unmanageable for his family. He has since stabilized with medication adjustments and a structured support system through a behavior plan and his care team. Michael is currently designated ALC and awaiting transition to a supportive group home. Staff at the hospital have identified ongoing impulsive behaviors that require structured supports. Michael's transition considerations include his new medications, the need for a behavior support plan that can be carried out in a community setting, staff training, and identifying environmental triggers in his new environment. We'll come back to Michael throughout the module to apply each concept in a practical way. You'll also see Michael's journey map throughout the module. It paints a visual representation of the transition process from hospital to home, with each stop corresponding to one of our learning objectives. We'll move through each stage step by step. We'll start with the first and most foundational component of transition planning, clinical readiness. This is often where transitions are either appropriately advanced or prematurely initiated. Clinical readiness goes beyond symptom stabilization. It includes several key components. Psychiatric stability, meaning symptoms are managed and not acutely escalating. Behavior predictability, meaning we have a reasonable understanding of behavioral patterns and triggers that can be taught to a new team of staff in a different environment, not just an acute care hospital. Environmental readiness, which refers to whether the receiving setting can support the individual. And finally, team readiness, including staff confidence and training. All of these need to be considered together, not in isolation. When we ask if someone is transition ready, we're not just asking whether they are stable, we're asking whether the system around them is ready. Clinical readiness, behavioral predictability, and environmental readiness all need to align. A person may be clinically stable, but if the environment or the supports are not prepared, the transition may still fail. Some key indicators of clinical readiness include a stable medication regime, reduced frequency or intensity of behavioral escalation, a clearly established treatment plan, and defined psychiatric follow-up. These indicators help us determine whether the individual can be supported safely outside of the hospital. Environmental readiness is just as critical. This includes whether staff have the appropriate training, whether staffing levels are sufficient, whether the physical environment is suitable, and whether behavior supports are in place and ready to use. Many transitions fail not because the individual isn't ready, but because the environment isn't. At this stage in the journey, we are assessing whether all components of readiness are aligned before moving forward. Let's apply this to Michael. His symptoms have stabilized, but he continues to require one-to-one support for impulsive behavior. Is he ready for transition? Take a moment to consider what additional factors you would need to assess before making that decision. Before determining readiness, we would need to consider whether the community setting can provide that level of staffing, whether staff are trained to manage his impulsivity, whether a behavior support plan is in place, and whether all the environmental triggers have been addressed. We would also want to ensure medication stability, follow-up supports, and a clear crisis response plan. These factors help determine whether the transition is safe and sustainable. This is where we begin to see the difference between clinical stability and true readiness. Once readiness is established, the next step is interdisciplinary training. Transitions are not managed by one provider. They require coordinated input across systems and teams. Effective interdisciplinary planning involves identifying who needs to be involved, clarifying roles and responsibilities, establishing clear communication pathways, and aligning expectation across teams. Without this, planning often happens in silos, which increases the risk of breakdown. A typical transition team may include hospital-based providers, such as physicians, nurses, and allied health professionals, as well as community-based partners, including direct support professionals, case managers, and family supports. Each brings a different perspective, and all are critical to a successful transition. One of the most common challenges in transition planning is unclear role definition. This can lead to assumptions about responsibility, missed information, and gaps in care. A key concept here is shared transition ownership, meaning responsibility is distributed but clearly defined. Once we understand the common breakdowns in transition planning, the focus shifts to how we actively address them. This starts with clearly defining ownership across each stage of the transition, so it always is clear who is responsible from admission through to community follow-up. We also need standardized handoffs so key information isn't dependent on informal or inconsistent communication. Structured tools like checklists or transition summaries can support this and reduce gaps. Importantly, behavioral information needs to be translated into language that is usable in community settings, not just clinically documented. And finally, accountability has to be built into the process, so it's clear who is sending, receiving, and following up on information. Together, this moves transitions from assumption-based to structured and shared processes. At this stage, the focus shifts from readiness to coordination, ensuring everyone involved understands their role. Returning to Michael, let's consider the following. In Michael's case, we can see how key responsibilities need to be clearly defined during the transition into community supports. This includes who is responsible for medication monitoring and follow-up, who is implementing the behavior support plan, and who takes the lead during a behavioral or psychiatric crisis. In complex transitions like these roles are often assumed rather than explicitly assigned, which can result in overlap, gaps in care, or uncertainty about who is accountable in real time. Michael's journey reinforces the importance of making role definition an explicit part of transition planning, rather than something left to interpretation at discharge. The third component of transition planning, and one of the most critical, is risk mitigation. When transitions fail, it is often not because risk was present, but because that risk was not clearly identified, understood, or planned for in a structured way. In practice, risk always presents during change. The key difference between successful and unsuccessful transitions is how proactively that risk is anticipated and managed across teams and environments. Effective risk mitigation relies on several core practices. First, we distinguish between tolerable and intolerable risk. Not all risk can or should be eliminated, so we need shared agreement on what can be safely managed within the community versus what requires more intensive intervention like readmission. Second, we identify early warning signs or indicators. These are small, observable changes in behavior, presentation, or environment that signals increasing risk. Third, we establish clear escalation pathways. This ensures staff know exactly who to contact, when to escalate concerns, and what steps to follow. Fourth, we align crisis response procedures across settings so that expectations are consistent whether the individual is at home, in a program, or out in the community. And finally, we develop contingency plans, especially what-if plans that guide action when things do not go as expected. The goal is not to eliminate all risk, which is not realistic, but to ensure risk is understood, anticipated, and managed consistently across teams and environments. When we think about risk and transitions, it is helpful to organize it into key domains. Behavioral risk refers to actions or patterns that may escalate or create safety concerns. Medical risk includes health conditions, medication considerations, and physical health stability. Environmental risk refers to the setting itself, including triggers, access to supports, and physical or sensory factors. And finally, support system risk relates to the availability, consistency, and coordination of the people supporting the individual. Looking at risk through all four of these lenses helps ensure we are not missing important factors that could impact transition success. Structured risk planning is about moving from general concerns to clear, actionable planning. It involves identifying what could reasonably happen during a transition, considering how likely each scenario is, and deciding in advance how the team will respond. This process is important because it reduces uncertainty. When staff understand both the risk and the agreed upon response, decision-making becomes more consistent across settings. It also increases confidence among teams because they are not making decisions in the moment without guidance. They are working from a shared plan. Tools like decision trees can support this consistency. A decision tree breaks down potential situations into clear pathways, outlining what action should be taken based on specific conditions or behaviors. For example, if a certain behavior is observed, the tree may guide staff to monitor, implement a specific strategy, or escalate to a housing supervisor. The value of a decision tree is that it reduces guesswork and supports quick, consistent responses, especially in higher stress situations. At this point in the journey map, we are focusing on operationalizing risk. That means we are not just identifying what the risks are, but translating them into clear, practical plans that staff can implement in real time. This step is what connects assessment to action. It ensures that risk identification leads directly into structured responses rather than remaining theoretical. Now, let's apply this to Michael. Take a moment to consider his presentation and history. You can refer to your handout if you do not remember his full profile. Which behaviors would you identify as red flags, meaning they may indicate increased risk or potential escalation? And which behaviors, while they're still important to note, are manageable within a community setting with the right supports in place? This distinction is critical. It directly informs whether a transition is appropriate at this time and what level of structure and support will be required to maintain safety and stability in the community. The final component is continuity of care. What happens after discharge is just as important as the planning that happens before it. Continuity of care is the final and essential component of transition planning. It refers to the active coordination that ensures supports do not stop at the point of discharge, but instead continue seamlessly across settings. Without continuity of care, even well-planned transitions can result in confusion, fragmentation, and avoidable readmissions. The goal is sustained stability, not just a successful discharge. Continuity of care refers to what happens after a person leaves one service and moves into another. In practice, transitions often fail not at discharge itself, but in the lack of coordination afterward. When communication is fragmented, supports may drop off, risk can increase, and individuals can destabilize quickly. The goal is to maintain consistency across settings so care does not reset at each transition point. A warm handoff is when one team directly communicates with the next team before the individual transitions. This can include phone calls, joint meetings, or case conferences. The purpose is to ensure key information is not lost in written documentation alone. It allows both teams to align on risks, supports, and expectations before the transition occurs. The SHED tool is an evidence-informed framework developed to support structured behavioral assessment and guide more objective understanding of behavior. It helps teams look at patterns, context, and possible unmet needs rather than relying on assumptions alone. This supports clear, observable documentation and helps translate behavioral information into practical strategies that can be shared across care settings. This is especially valuable during transitions where consistent communication reduces gaps in care. In Michael's case, using a tool like the SHED would help ensure important behavioral information is clearly communicated to community providers, supporting continuity and reducing uncertainty during his transition. Documentation should support continuity, not overwhelm the receiving team. The goal is not to transfer every piece of historical information, but to communicate what is functionally relevant for supports. This includes current risks, effective strategies, and known triggers. Excessive or poorly organized documentation can delay care or obscure important information. Early follow-up is critical. Follow-up is critical in the early days and weeks after a transition. This may include scheduled appointments, check-ins from staff, and monitoring for changes in behavior or functioning. The goal is early identification of instability so that supports can be adjusted before a crisis develops. This stage is often where preventable hospital readmissions occur if supports are not active. Continuity of care is not a one-time event. It requires ongoing feedback between all involved parties. This includes direct support professionals, outpatient clinical teams, and external providers. Regular communication ensures that changes in behavior, health, or functioning are identified early and responded to appropriately. Strong feedback loops help maintain stability and reduce the likelihood of rapid rehospitalization. At this final stage of the journey map, the focus is on maintaining stability and preventing rehospitalization. At this stage, we bring in lived experience to ground our clinical planning in real-world transition experiences. Michael's reflections remind us that transitions are not only logistical or clinical events, they are also deeply personal experiences that can bring uncertainty, stress, and disruption. For Jenny, frequent moves created instability and uncertainty about what would come next. She also described the challenge of feeling misunderstood, particularly when others were still learning how to understand and adapt to their medical needs. These reflections highlight an important reminder. While care teams may focus on discharge planning and clinical readiness, the individual may be experiencing fear, uncertainty, or loss of control. Incorporating lived experience helps us better understand what meaningful support looks like and allows planning to be more responsive, individualized, and person-centered. As we've explored throughout this module, transitions are complex, and even small gaps can have significant impacts on continuity of care. Clear risk identification, clearly defined roles, and strong follow-up planning all contribute to safer and more effective transitions. Discharge is not the end of care. It is one step within a large continuum of support. What happens after discharge often determines whether a transition is successful and sustainable. Each of us plays an important role in supporting what comes next. Thank you for your time and engagement with this module. As you reflect on this module, consider your own experiences supporting transitions. Think about a time when there was uncertainty during a transition process. Where were the gaps in communication, role clarity, or follow-up planning? What indicators of risk may have been missed, unclear, or difficult to measure? And most importantly, what might you approach differently next time? Reflective practice strengthens our ability to continuously improve transition planning and provide safer, more responsive care. In our next module, Fostering Resiliency and Trust in Developmental Services, Cassie and Erica will explore the relational foundations that support effective care. This includes building rapport, applying trauma-informed approaches to person-centered support, strengthening collaboration, and understanding the strategies that either support or hinder positive team dynamics. These concepts build directly on today's discussion by helping us understand how strong relationships and inclusive practice support long-term stability and success. The references and additional resources included here are available to you to support continued learning and reflection. These materials offer further guidance on transition planning, person-centered practice, interdisciplinary collaboration, and developmental service supports. You are encouraged to review these resources to deepen your understanding and explore practical strategies that can support the important work that you do. Thank you for taking the time to complete this module. We appreciate your commitment to strengthening transition practices and improving outcomes for the individuals we support.